Testing 1, 2. Hello, everybody. This is Margaret Harris in WHO Headquarters, Geneva, welcoming you to our Global Press Conference on COVID-19 today, Friday, November 27. We have with us in the room our WHO Director General, Dr. Tedros. We also have Dr. Mike Ryan, Executive Director of our Emergencies Program, Dr. Maria Van Kerkhove, Technical Lead for COVID-19, and also Dr. Hanan Balgni, our Assistant Director General for Antimicrobial Resistance, and Dr. Peter Ben Emberek, a scientist specializing in zoonosis and food safety. And we also have next to me here Dr. Kate O'Brien, our Director of Immunization, Vaccines and Biologicals. They will all be here to answer your questions, so please think about your questions now and get them ready. As usual, we are translating this simultaneously in the 6 official languages, plus Portuguese and Hindi, and we'll be posting the Director General's remarks and an audio file of the press conference on the web as soon as possible. Transcripts will be available later. So now, without further delay, I will hand over to Dr. Tedros to give us his opening remarks. Dr. Tedros, you have the floor.
Thank you, Margaret. Good morning, good afternoon, and good evening. COVID-19 is an uneven pandemic. All countries have been affected, but not all countries have been affected equally. 70% of cases and deaths are in just 4 countries. And there are many countries all over the world that have shown COVID-19 can be controlled with existing tools. One of the things all these countries have in common is an emphasis on testing. Since the beginning of the pandemic, WHO has emphasized the importance of testing and provide the tools for countries to do it. On the 13th of January, in collaboration with the experts we work with, we published the first instructions for producing tests, just 2 weeks after the first cases were reported. Since then, we have shipped millions of tests and other diagnostic products all over the world. And we have also worked with countries to increase testing capacity. For example, at the start of the pandemic, just 2 African countries had lab testing capacity for COVID-19. By the end of February, 32 countries in Africa had testing capacity. And now, all countries can test for COVID-19. But we continue to need more and better tests that are easy to use, cheap, reliable, and fast, so patients can be cared for and contacts can be traced. In September, WHO published our target product profiles for diagnostics, which outline the features needed for new tests. Many manufacturers around the world have been working to develop these tests. Through the diagnostics pillar of the Access to COVID-19 Tools Accelerator, WHO, FIND, the Global Fund, and other partners are working together to evaluate more than 50 diagnostics, including self-administered tests. Once these tests are validated and approved, they can be incorporated into national strategies. In September, WHO issued the first emergency use listing for an antigen-based rapid diagnostic test, which can return a result in just 15 minutes, along with guidance on where best to use these rapid tests. Together with our partners, we also announced an agreement to purchase 120 million of these tests for 68 low and middle-income countries in all regions of the world. We're now shipping these tests around the world. Last week, WHO and FIND also launched a comprehensive training package for health workers on the use of rapid antigen tests. But nearly 2 months later, we still face a funding gap of $500 million to maximize the use of rapid tests. As vaccines are rolled out, testing will continue to play a vital role. Initially, health workers, older people, and other at-risk groups will be prioritized for vaccination. That will still leave the virus with a lot of room to move, and testing will remain a vital tool for controlling the pandemic. If you don't know where the virus is, you can't stop it. If you don't know who has the virus, you can't isolate them, care for them, or trace their contacts. But testing must be strategic in support of clear public health objectives. Everyone who needs a test should get a test. WHO's guidance outlines how countries can test strategically based on their transmission scenario. It's also important to remember that although testing is vital, it's only part of the strategy. Testing is the spotlight that shows where the virus is. Investments in testing must be matched by investments in isolation facilities, clinical care, protecting health workers, contact tracing, cluster investigation, and supported quarantine. WHO is continuing to support countries in different transmission scenarios to use testing strategically to bring outbreaks under control. Finally, this week, WHO published new guidelines on physical activity and sedentary behavior. Physical activity is essential for physical and mental health throughout life. But 1 in 4 adults and 4 in 5 adolescents don't get enough physical activity. The new guidelines recommend between 150 and 300 minutes of moderate to vigorous activity per week for all adults, and an average of 60 minutes per day for children and adolescents. COVID-19 has resulted in restrictions of many types, but everyone can remain active, whether that's doing a workout at home or going out for a walk, a run, or a ride. It's one way all of us can add years to life and life to years. Every move counts. I thank you.
Thank you very much, Dr. Tedros. I will now open the floor to questions. I should let you know that I omitted to mention that we also have joining us remotely Dr. Mariangela Shumau, our Assistant Director General for Access to Medicines and Health Technologies, Dr. Bruce Aylward, Senior Advisor to the Director General who leads on the ACT Accelerator, and Dr. Soumya Swaminathan, our Chief Scientist. So once again, remember you have a wealth of expertise here to answer your questions. It will be an hour, so if I do not get to everybody, I apologize in advance. We will start the questions with Simon Ateba from Today News Africa. Simon, please unmute yourself and go ahead.
Thank you, Margaret, for taking my question. This is Simon Ateba from Today News Africa in Washington, D.C. Pfizer has applied for emergency use of its COVID-19 vaccine from the FDA here in the USA, and is likely to be approved soon. But the Pfizer vaccine has to be kept at minus 70 degrees Celsius and needs special storage requirement not found in many hospitals, even here in the USA. With Africa having other problems, such as lack of constant electricity in many hospitals, what needs to be done between now and then for the Pfizer vaccine to be shipped to African countries? Or is it even realistic to distribute the vaccine in countries such as Nigeria, where there has never been a constant electricity in the past 50 years? Thank you.
Thank you, Simon. Dr. Kate O'Brien will answer first, and maybe others will join.
Thanks for that question. The Pfizer vaccine, as you indicated, does require what we refer to as an ultra-cold chain, so very, very cold temperatures. And we do have one other vaccine that has required that degree of temperature, very cold temperature, and that's the Merck Ebola vaccine. So we do have experience in a number of countries, specifically in Africa, of being able to deploy a vaccine with that ultra-cold chain requirement. It has not been deployed across every country in the world, of course. So as we anticipate the use of the Pfizer vaccine, the intention is certainly to be able to use it along with other vaccines, because no one vaccine is going to have adequate supply, nor will any one vaccine necessarily be suitably have suitable operational characteristics to meet all of the needs. But specifically on the Pfizer vaccine, Pfizer has developed a special shipper for the vaccines, and even without the use of in-country ultra-cold chain freezers, that shipper can actually maintain the temperature of the vaccine for a substantial number of days, in the range of 10 to 15, depending on how often you open the box. And furthermore, the Pfizer vaccine can be maintained at refrigerated temperatures for 5 days prior to the final use of the vaccine. In addition to that, we do have technology that can help with the delivery of ultra-cold chain. There are portable freezers referred to as Arctech and other products that don't require electricity and that can maintain the temperature of the vaccine at this minus 70 degree for a period of days. And finally, with the use of dry ice, there are ways that we can maintain vaccines at this low temperature. But you do make a very important point, which is this is not a strategy that is in place already in countries, including high-income countries. So every country is going to have to work very hard and is going to have to innovate around systems to actually deliver vaccines that do have an ultra-cold chain. And part of the approach that many countries may take is to choose to use vaccines that require an ultra-cold chain for only certain portions of the population that need to be vaccinated. For example, using that vaccine among healthcare workers, where facilities might be the place where immunization would take place, and therefore installation of a minus 70 freezer would be more simple, recognizing also the need that you described about the need for electricity to be maintained in those facilities. So I think the main message is that we do have technology. There is demonstrated experience of delivering ultra-cold chain vaccines, even in some of the most difficult and remote areas. But that has also taken enormous resources to do that. So what we do need is we need a variety of vaccines that have different characteristics, and as you know, in the past several weeks have been, through press release, the release of efficacy data on other vaccines that are either kept at minus 20 or at refrigerated temperatures, which will certainly ease the distribution and use of vaccines. So I hope that answers your question.
Thank you. I'm just looking in the room to see if there's anyone else who wants to add anything. I think not. Do we have anyone on the line who would like to add? No. Okay. So we'll go to the next question, which is for Helen Branswell. Helen, could you unmute yourself and ask your question?
Hi, thanks for taking my question. Hello to you all. Can I ask about vaccines and herd immunity? Now that we're starting to get a sense of how efficacious these vaccines could be, are we able to sort of calculate how many people in a population would need to be vaccinated to get to herd immunity? Is it something that is, achievable at this point?
Okay, I can take that. Another great question. So the concept of herd immunity, of course, is the idea that there can be people who have the appearance of immunity, in other words, are protected against disease, but themselves are not actually vaccinated. And the way that that happens is that it's at some point the number of people around them in the community are themselves immune, and as a result the non-immune people are protected because the virus or the pathogen simply has very limited ability to move around in the community. So just for those who maybe aren't familiar with what herd immunity is, I'll just clarify that. And so, Helen, the point about herd immunity is really what is the performance and the ability of the vaccines, or frankly, natural infection, to protect against future infection and therefore acquisition and transmission to somebody else. And what we really need to know is what the vaccines that are being developed, each of them, what their ability is to interrupt the acquisition of infection. But it's not the only way that herd immunity can be achieved. We do want to know about whether there's a reduction in people getting infected in their nose, in their respiratory tract, even without getting disease. But also, do the vaccines change the amount of time that you're actually infected? Does it change the density of the infection? And does it change the transmissibility to another person? And those are all really important characteristics. We don't know the proportion of the population that would need to be immunized because we haven't observed that yet. But the answer to that can come from modeling studies that would that tell us under certain conditions what proportion of the population would need to be immunized. And so those modeling studies, a number of them have been done, and under a variety of conditions have concluded that somewhere around 60 to 70% of the population would need to be immune, or presumably through immunization, in order to achieve a reduction or an interruption of transmission of the virus. Now that's, of course, predicated on what the performance of the vaccine would be. So it's really important that we actually start to get more information about what the vaccines do, not just for preventing disease, but for actually preventing the acquisition of the virus, an infection, and the characteristics of that infection.
Thanks, Kate. Really clear. And just maybe to add that we also need to continue our understanding of the transmission dynamics of the virus, because it clearly does not spread through a community like a common linear wave. And herd immunity concepts are built around that idea, that the disease spreads evenly through the community, and then everyone's absolute risk of being infected is about the same. And then if you have lots of protected people surrounding those who are unprotected, there's a barrier, there's a firewall around someone who's not vaccinated, a firewall of vaccinated people. And therefore you can achieve control and eradication sometimes without vaccinating everybody. That's the principle, I think, of herd immunity. But what we've seen with this virus is, I won't assign it cleverness, but the virus is very opportunistic. And we've seen that the virus can spread in particular circumstances. We've seen in many clusters that only 20% of the cases go on to transmit to others, 80% don't transmit to anybody else. We've seen super spreading events, certain contexts and certain groups who mix and the disease can explode. So it may be that it will take some very clever vaccination strategies to highly target people in our society who are more likely to carry, transmit and super spread with this virus. So just using an absolute number, Helen, may not be the best. I think we'll need some numbers to guide us in terms of policy, but I think we'll need to be much more surgical and precise in exactly who we target for vaccination. It may be much more important to target certain sections of the community than it will be to necessarily target some others who may not be participating in transmission as much. So I think the answers will come based on what Kate has said, but we also, I think, will need to remain vigilant. As long as there's a potential for super spreading events, there's always the chance that a very small incidence can lead to a large cluster of cases, even in the context of high levels of transmission or high levels of vaccination. And I think we'll need to be very, very careful to make sure we send the right messages to people. Vaccination will have a major impact on mortality, we hope. We hope it will have a very major impact on transmission and control. But I don't think anyone can promise eradication of this virus until we understand much more about the vaccine and much more about how the vaccines work in the real world, and until we understand much more about the details of transmission of this virus.
Yeah, let me just, that's such a great point, Mike, and I just want to give an example to sort of bring it to life a little bit. Last year we had 2019, we had a terrible year of measles outbreaks around the world. And many of those outbreaks were happening in countries that had very high measles vaccine coverage. But it wasn't about the whole country's coverage that was important. It was about the sub-communities, the sub-national coverage. And so you absolutely can have lower vaccine coverage in a community that is a big enough community where a virus can spread. So I think Mike's made a really good point that we shouldn't be anchoring on a hypothetical number from modeling that somehow is going to be the whole country's coverage, but it's really about where is the virus at any given time and how much of a firewall is there for the virus in that community at that time when there are infectious people in the community. So I hope that gives an example of what Mike was trying to explain.
Thank you, Dr. O'Brien. Dr. Ryan, I think Dr. Sumia Swaminathan would like to add something as well.
I wanted to make a very quick point, Helen, because we were talking about vaccines with over 90% efficacy here. That's what we've seen from a couple of the early results. Just to point out that the mRNA vaccines are particularly good at stimulating innate immunity. And so what you see in the short term, we've only got data, for 2 months of follow-up, could be the effect of a non-specific innate immune response plus specific immunity. So while we hope that these vaccines do have over 90% efficacy, it would be wise to wait a little bit to look at the follow-up results from people in this trial. And that's why it's so important that the trials are continued, that they continue as placebo-controlled, double-blinded trials as long as possible, as long as it's ethically and practically feasible to do that, because there are a lot of questions that we still need to understand, particularly, as I said, about duration of protection, about the impact on severe illness and on transmission of infection, and about the efficacy in different subpopulations, including the older age adults. So just something to keep in mind, especially when we see these very, very high efficacy readouts, is that we do need data over longer periods of time to make sure that those are actually the long-term protective effects. I just wanted to make that in addition to what's been said by Mike and Kate. Thanks.
Thank you, Dr. Swaminathan. So our next question goes to Jamil Chade. Jamil from Brazilian media. Jamil, unmute yourself, please, and ask your question.
Yes, thank you, Margaret. Thank you for taking my question. This is a question to Dr. Ryan. Could you tell us a little bit of the scenario for Brazil at this current stage? Can we talk about a second wave already in terms of Brazil, or the first wave has never ended for us to be calling it a second wave? And what lessons from Europe could Brazil learn in this eventual second wave? Thank you.
Let me get my microphone. Yes, and I think there are lessons there for all of Central and South America, and most of Central and South America went through a very tough time in terms of cases and deaths, and the numbers have progressively fallen in most countries over a couple of months. But now we see the prospect of numbers increasing again, and I think there are lessons to be learned from North America, lessons to be learned from Europe. I think what we've seen is where countries have taken decisive action to try and reduce community transmission, they've managed to turn that curve around. But that's taken quite a deal of cooperation from people in terms of understanding the need to do more physical distance and to really focus on mask wearing, to focus on hygiene, and in some cases to accept restrictions of movement and so-called lockdowns. That's a very difficult thing to enact, particularly in highly populated areas where many people are dependent on going to work and on day salaries, where poverty is an issue, and it's very hard to expect people to give up their only access to socioeconomic gain by staying home. So I think the lessons we're seeing, I think now in Europe certainly, is countries that act early and act decisively get a benefit, and that the transmission turns around relatively quickly once you're able to make a community-based intervention, and particularly when the community come on board with that. And we've seen a significant shift in behaviour in countries towards people really working not only on avoiding transmission in large settings or in the public environment, but really looking at transmission in the household and trying to reduce the risk of secondary transmission at home, which has become a major factor in Europe and North America for transmission. Focusing on protecting yourself and protecting others, that individual education, individual knowledge transfer, and getting that clear and consistent messaging out. I think Europe this time round has done a much better job in having consistent processes across all of its, let's look at the European Union, the member states of the European Union have aligned better on the types of measures. They've looked the same in how they've approached things much more. There's been a consistency in that messaging, and if you see the European Union as a sort of a federation of states, and you look at a very large country like Brazil or other large federated states, that ability to negotiate with and reach consensus with subnational entities and find consensus on how to move forward together so that populations get clear and consistent messaging, clear decisions on public health action, clear decision on mandates that are to be implemented by government. I think that's what we've seen. And we've also seen previously, for example, the Brazilian Health Service reacted wonderfully to the last surge in cases, and certainly so many brave frontline health workers in Brazil, but they were pushed to the very limits of their capacities, both in terms of equipment and their own fatigue, and therefore it's going to be very important if, as numbers increase, that they are protected, that the health system is protected from a large surge of cases. You cannot assume that a health system can take the same beating a second time round. And what we have seen too, as case fatality rates have dropped, and in every age group, and what we've seen is higher recovery rates for all age groups, and that's been over the summer, and that's been very much down to doctors and nurses having more time with patients, having more time to give clinical care. If we get back to a situation where intensive care units are overwhelmed, we will see the death rates rise again unnecessarily. So all of the things we've said before, what we need now is to do it quicker, to do it more consistently, in a more coordinated way, because we've learned what works. There is an excuse the first time around. We're all learning, we're all adapting, we're all testing what our populations will accept or won't accept. A second time around, you need to have done that learning and understand how to do better this time. I think countries in Europe have really tried to look at how they can improve what they are doing, and I think they have improved this time around. Hopefully there are lessons there and learnings there for countries who may now be entering a second surge or a second phase. Maria?
Yeah, I'd like to add to what Mike has said there. As he said, there's a lot of lessons to learn. I think one of the messages we need to continue to say is, even as case numbers are coming down, all countries need to remain vigilant. You've heard us say this before, but we really need to emphasize this again. Do not let your guard down. It is good to see the measures taking effect and transmission going down, but it is not time to let up. And it's time to even scale up. So in situations where you're bringing this under control, it is time to scale up your public health infrastructure still. Work on making sure that you have adequate workforce to do active case finding, to conduct those tests, to use those tests strategically, as you heard us say many times, and the Director General emphasize again today, to work to have your health systems be ready for any potential resurgence. That includes making sure you have ample hospital beds, ICU beds, supplies, PPE for your staff. It is still time to scale up. I know that sounds like it's probably not, doesn't make sense. If case numbers are going down, why do I need to scale up? It's just use the time appropriately to prepare. and to revise, as Mike has said, we're learning, and so you can tailor your approach to be more agile to where is needed and use those resources best if you have any resurgence. And be very quick and decisive when there is a resurgence. So the earlier the action you have, if you have that resurgence, the quicker you can prevent clusters of cases becoming clusters, and clusters turning into community transmission. But what we don't want to see is situations where you're moving from a so-called lockdown state to bringing the virus under control to moving to a so-called lockdown state. And it's really important at that time when transmission is brought under control that we don't give up, we don't let our guard down. We still need to ensure that everyone remains vigilant. Everybody knows that this is not yet over. We're working towards bringing this over altogether, but we still need to think about what we do every day. We still need to take a risk-based approach throughout the actions that we have every day until this pandemic is over. And I think that we just need to make sure that we just don't let up. And I think that's something that we have to hammer in because there is no reason to have a second surge. There is no reason to have another wave or another surge. It is within our power to be able to keep transmission low. And we've seen dozens of countries show us that it can be brought under control and it can stay under control.
Thank you very much, Dr. Ryan and Dr. Van Kerkhove. The next question goes to Bayram from Andalu. Bayram, can you unmute yourself and please ask your question?
Thank you, Margaret, for taking my question. According to certain sewage samples in Marseille, France, it seems the cases of COVID-19 already started to decline before France put the current lockdown, which could mean that the lockdown was not really efficient. Some specialists even said getting people confined in closed settings at home increased the cases after the start of lockdowns. And that is also visible in sewage samples. Do you have any comment on that? Thank you so much.
So your question was about whether or not lockdowns work and do they exacerbate transmission by confining people. Is that correct, Bayram?
Yeah, it is correct, yes.
So thanks for that question. It's a very important one because if people are asked to stay at home and there's stay-at-home orders and there is virus circulating in the community, if there is somebody that is infected and they're put in the home, there's the possibility that the virus can transmit within the home. That's why one measure alone is not enough. We need to make sure that in addition to any measures that are put in place, we still are conducting strategic testing for any cases who are suspect cases. They receive a test, and then the public health actions are followed. So if a case is identified, make sure that they are isolated in a medical facility, and all cases need to be isolated in a medical facility or at home away from others. In the situation where people are going home all at once, we need to make sure that if we're feeling unwell, that we stay away from others within our home. We wear a mask in the home and others in the home wear a mask, especially if people are feeling unwell. But there is a risk that by putting people all at home, you can put the virus there and it could spread. But again, we need to make sure that these confinement measures or these stay-at-home measures are not used in isolation. They have to be used with other measures as well. The stay-at-home measures do take the heat out of transmission in some respects in terms of transmission in the community, but it is possible that it brings it home, so you have to take the precautions at home as well.
Thank you very much, Dr. Van Kerkhove. The next question goes to Shane Zhu from CCTV. Shane, could you unmute yourself and please go ahead?
Okay, thank you, Margaret. My question is for Dr. Ryan. It's actually a follow-up question about his last time comments on virus origin. So Dr. Ryan, as you mentioned during the previous briefing, there are increasingly more and more evidence about the existence of this virus on other species and in wastewater or patients around the world. You also mentioned some cases were not directly linked to Wuhan seafood market in the first outbreak, and not sure yet where the first case of breaching the species barrier. And maybe the market was only the place for amplification. And there are also new evidence these days suggesting that the virus existed long before the outbreak in Wuhan. For example, the Italian researchers found the virus in samples from last September. Does it mean that the case zero or several case zero could be outside of Wuhan, outside of China? And is there a possibility that the virus already circulated in humans outside of China before the outbreak in Wuhan, but without being noticed? Thank you.
Thank you. Yeah, I think we need to be careful with our speculation here. There are lots of different observations that have occurred around the world, but the idea that humans can infect minks and minks can infect humans is very clear. But there's no evidence that mammals in a European environment were the source of this disease originally for humans or outside China. The issue for us, and from our perspective, and again, Dr. Tedros, myself, and others have been clear on this since the beginning, and this is why we sent an advanced team to China. This is why we've been discussing this issue since February, since the first research and development roadmap, where the animal origins studies were seen as the top priority. This is why the World Health Assembly discussed this and issued a World Health Assembly Resolution 73.1 identifying the origin studies as a very important issue, which was consensus between all member states. This is why we sent an advanced team to China to look at the issues and negotiate on the best possible way to move forward with studies. We identified in terms of reference 2 phases of studies. Phase 1 studies really identify many of the questions you've actually laid out there are laid out within the Phase 1 studies that we've agreed with our Chinese colleagues. We've had a high level of engagement with those colleagues at a virtual level, discussing, and Peter Bremberg is here, and I'd ask Peter to give you an update on the natures of those discussions. But it is clear from a public health perspective that you start your investigations where the human cases first emerged. In that regard, and the first cluster of cases, and again, the astute clinicians in Wuhan picked up a cluster of unusual atypical pneumonia, and to an extent probably because there was an association in time and a geographic association with the market, it triggered in their minds a suspicion, and they reported that disease to the appropriate authorities, and then there was a subsequent investigation. So from that perspective, that was the event which triggered the response and the investigation. And that's very important, and the physicians and others and people involved in that initial detection deserve credit. The question then is, what was the original origin of the virus? And nobody has that answer. And that is what the Phase 1 studies were to be about and are about, and there's a series of Phase 2 follow-up studies planned once we have the answers to those questions. So we believe we need to make progress on those studies and understand what our Chinese colleagues have investigated, the results of those investigations, and we are working with them to send a team to the ground to both review the results of the Phase 1 trials and look at other studies that may need to be done. After that, the evidence should take us where we need to go. But to speculate on where the virus emerged precisely without starting where the human disease emerged, for us, doesn't represent the best way forward. However, at the same time, we are working with scientists all over the world. We are open, we receive information. There are publications being made almost every week on animal studies, and we will continue to track that, and we will take every detection in France, in Spain, in Italy, very seriously, and we will examine each and every one of them. And we have taken action directly with researchers, Maria may speak to that, and how we've engaged with researchers who've published unusual results from other countries to try and validate those results as well. So I think it's highly speculative for us to say that the disease did not emerge in China. What we do know is the first clusters of human cases that were detected were in Wuhan in China. There was a massive response to contain that disease there, and we look forward to working with our Chinese colleagues, our Chinese scientific colleagues, to understand better the origins of the virus within China or beyond China, wherever that leads. Peter.
Thank you, Mike. And yes, as you said, the international team has started to work with their counterparts in China. updating each other on existing and past studies and ongoing studies. And we are starting now to discuss the famous phase 1 studies, the studies that needs to be conducted in and around Wuhan to look back at what happened back in late 2019. We need to push back our understanding of what happened before the detection of the initial cases. We have to make the link between that event and the original animal that was the source of this virus. We know that the virus belonged to a group of viruses that have their natural niche in bats, in certain families of bats, but between bats and the event in Wuhan, we have a big gap, and that's the purpose of all these studies, is to fill that gap and understand what happened between these two events and where it happens. But for the time being, we have to start where we have the first solid clues, and these are the first detected human cases in Wuhan in late 2019. Thank you.
Thanks. Just a couple of comments to add on to what Mike and what Peter has said. So there's some additional work that is ongoing as well, looking at some wastewater studies. Some countries have looked at retrospective samples of wastewater. There was a study that hasn't been published that had one sample that they found RNA, but that hasn't been published. And there are other studies that found RNA in December in Europe. In Italy. There's one study that was published very recently looking at it's a serologic study, seroassay study, looking at some samples from Italy from a cancer screening institute in the fall. And they found positive samples, seropositive samples in September using an ELISA test, and in October using microneutralization. We've reached out to these researchers, and they have generously offered to work with us and to collaborate with us on some further studies looking at those samples, just making sure that we can do some further studies with samples from that cancer institute. In addition to that, there are a lot of analyses that are ongoing looking at genetic sequences. So as you know, there are more than 200,000 full genome sequences that have been made available, and this is an incredible global collaboration of researchers all over the world. We still need more, so please continue to share those sequences. And there are phylogenetic analyses, and there are really incredible scientists that are looking at these to look at how this helps shape our understanding of this virus and the way that this virus moves. So there are a lot of sources of information, but as Mike has pointed out, as Peter has pointed out, the studies need to begin where the first cases were detected, in Wuhan, where those first cases were detected in December. And then we follow the science, wherever the science leads us in terms of further investigations and studies that need to be undertaken. But there's a wonderful global collaboration that is ongoing, and these studies will be conducted.
Thank you, Dr. Van Kerkhoff. One more. Sorry, Dr. Tedros.
So on the study of the origin of the virus, one thing that has to be clear is the study will start from China, Wuhan, where the first report came. And then from there, based on the findings, we can go anywhere. So I think it's better to really underline that. Thank you.
Thank you, Dr. Tedros. So the next question goes to Stephanie Nebahay from Reuters. Stephanie, please unmute yourself and go ahead.
Thank you. Thanks for taking my question. I wondered if either Kate O'Brien or Dr. Sumya would like to comment on this, the AstraZeneca results and the idea of needing a new trial in effect to check the findings of the lower dosage, the efficacy with the lower dosage, that first part. So I wondered if you think that is necessary, and whether the current results are reliable enough to give regulators a full picture. Thank you.
I can start and then pass over to Soumya. I think the first thing to say is what we've seen is a press release. And what is really the next most important step is that the data really needs to be evaluated based on more than a press release. There's only, first of all, a limited amount that can be said in a press release, and secondly, it really needs to be reviewed in terms of the data and questions asked about the data that may come up in the course of the review. So it's difficult to weigh in on this. I think what we can emphasize, though, is that from what we understand about the press release, there is certainly something interesting that has been observed, but there are many reasons that could underlie the differences that were observed. And so certainly more information is needed, and that includes evaluations of the immune response in the trial as well. So I think it's too early for us to say anything about what we make of the data and what is needed next. What we really need to see is more than a press release, and to really see the data and have a chance to ask the questions that are needed. I'll pass over to Soumya.
Yeah, thanks, Kate. Maybe just to add to that, again, what we know is what we've seen from the press release, and it appears that less than 3,000 people were given the schedule with the half dose followed by the full dose of the vaccine. And we've also understand that those people were all under 55, so it didn't have anyone over 55 in that group, whereas the other group of about 8,000 plus people who were given the full dose and the full dose, actually there were larger numbers, and it also included different age groups. So it's very hard to compare these two groups, and I would say the numbers are still small to really come to any definitive conclusions. Now, of course, the advantage of using a smaller dose, particularly if you're getting a higher efficacy, is great. You can save on the vaccine, and at the same time, you're benefiting from higher efficacy. But I think it would be speculation at this point. We've heard from AstraZeneca that they would like to do a full trial of this schedule, because the other trials that are ongoing now are the two full doses. And so if we are to explore this hypothesis of having perhaps a better efficacy with a lower dose, then it would need a trial. And so the last point I'd make is that this is the reason that WHO actually convened experts very early on in the pandemic to really start thinking about what should be the benchmarks, the target product profiles for a good vaccine, and also thinking about what would be a good trial design, really to answer the questions around efficacy in prevention of disease, prevention of severe disease, and prevention of infection as a secondary endpoint. And we worked with statisticians, with experts to really come up with what a trial design would look like. And I must say that it's been very encouraging to see that many of the manufacturers and developers have actually published their protocols. So you can see exactly how they're going to do it, what they're going to do, at what steps they're going to do the interim analysis, when they're going to unblind the data, and what the endpoints are, primary and secondary endpoints, both for efficacy and safety. So I think that transparency and sharing is extremely important for scientists to evaluate, to compare also between different vaccines, because let's not forget, we have dozens of vaccines in the pipeline, and we are going to be in a situation where we might have a variety of different vaccines with a variety of different results, and people are going to have to make decisions and choices. And so it's really good to have apples to compare with apples, and therefore for all trialists, and perhaps this is a plea to those who haven't yet published their protocols and made them available. It's good, it's easy for the regulatory agencies as well. It's good for organizations like the WHO that have to make decisions based on comparisons. And it's good for citizens also in general. It generally builds a trust in the process of vaccine development. Thank you.
Thank you, Dr. Swaminathan and Dr. O'Brien. The next question goes to Shoko from NHK. Shoko, can you unmute yourself and ask your question?
Hello, Margaret. Can you hear me?
Very well. Please go ahead.
Thank you for taking my question. So Dr. Tedros just mentioned the study of the origin of the virus will start in China, but is the international mission going to the field in Wuhan? Thank you.
Yes, it's correct. It will go to Wuhan. It will travel to Wuhan. Thank you.
Okay, thank you. That was an easy question. The next question goes to Musa from Al Mayadin TV. Musa, please unmute yourself and go ahead, ask your question.
You listen me?
Very well. Please go ahead.
Okay. My question is in Arabic, please. السؤال للسيد تدرس تطالبون دائما بتوزيع عادل للقاحات يعني ممن تطلبون مساعدة الدول الفقيرة هل تطلبون ذلك من الدول الغنية لتساعد الدول الفقيرة أم من شركات تصنيع الأدوية هل منظمة الصحة العالمية لها القدرة على تقديم اللقاحات أو جزء من هذه اللقاحات مجانا للدول الفقيرة وسؤال آخر للسيدة أوبريان ماذا عن اللقاح الروسي مقارنة مع اللقاحات الأخرى هل لديكم بيانات عن اللقاح الروسي شكرا
Thank you. Yes, this sounds like a question. The first question is about COVAX, really, about distribution of vaccines, and the second one is specifically to Dr. O'Brien. Dr. Aylward, are you online? If not, we can start with Dr. O'Brien and then move over to Dr. Aylward. How about that? Dr. Mariangela Shimau as well will be able to speak to that as well, I think, yeah. So we'll start with Dr. O'Brien.
Thank you. With respect to the, I'll start with just some comments on the fair allocation of vaccines. There is, as I think people are aware, WHO has, through the ACT Accelerator and the COVID vaccine component of the ACT Accelerator is a partner in the COVAX facility, which is the global mechanism for all countries around the world to aggregate demand and the financing for vaccines and to assure that there is fair and equitable access through the WHO Fair and Equitable Access Mechanism, which can be then applied to those vaccines that are procured through the COVAX facility. And that facility has a component of the facility for the 92 countries or the 92 countries that will be supported for the procurement of vaccine. And it also includes a part of the facility where countries who are wealthier countries would themselves pay for vaccines that are procured through the facility. So there is a mechanism for all countries to have fair and equitable access, and for those countries that are not able to themselves afford vaccines to be supported to do that. Though that support is coming from overseas official development assistance and from contributions from other sources. And there is, of course, a relationship for entering into contracts with manufacturers, and those discussions with manufacturers are well underway for the facility, with a number of agreements made already and others that are fully being developed at this point. And perhaps Mariangela would like to say a little bit more about the allocation. We have developed an allocation mechanism that WHO has led, and that really is about allocating vaccine in a fair and equitable way across all of the countries. For the first 20%, all countries would receive vaccine and in an equal rate, and following that, for vaccines beyond the 20% of the population, for countries that want to go beyond that level, there may be consideration if we're still in supply shortage about the pace that countries would get vaccines would account for vulnerability and the threat of COVID. So I'm sure Mariangela might want to say more about that. On the issue of the Russian vaccine, the Gamaleya vaccine, again, we've had a press release from the Gamaleya vaccine in the past several days reporting very high efficacy from this viral vector vaccine. And this is also very welcome news, along with the other 3 manufacturers that have reported efficacy data. But I want to emphasize again what we emphasized before is these are data that have been reported through press releases. And what is really important and critical at this point is for those data to be reviewed by regulators and reviewed at WHO also for policy reasons and for regulatory reasons, for WHO pre-qualification or emergency use listing, and for those data to be in the public domain through the usual mechanisms that are used, which is through the peer-reviewed publication process. So we're really eager to see the results of all of the reports and of any vaccine that is able to report results from phase 3 clinical trials on the prevention of disease. So I'll see, I don't know if Bruce is on the line or if Mariangela would like to join in or Sumya. Thank you.
Dr. Mariangela's on the line, I believe. So over to you.
Thank you. Thank you, Kate, for a very, I almost have nothing else to add except on the allocation, because I think Dr. O'Brien has explained quite well. But I would like to add regarding the vaccines, the Russian vaccine, and because WHO, you know, we have mentioned in weeks before, WHO has issued an expression of interest to assess for emergency use listing candidate vaccines on phase 2B and phase 3. And this expression is still open. There are several of these the advanced candidates on phase 3 that have expressed interest and are in discussions with WHO, exchanging information. And like Dr. O'Brien has mentioned, we still have to see some of the not only the clinical data, but also the good manufacturing practices data that are part of what, when a country does an emergency use authorization or WHO does an emergency use listing, it's based on a series of important information, non-clinical, clinical, and referring to manufacturing practices. So this is work ongoing, and I think Dr. O'Brien has explained quite well the allocation. Thank you, Kate.
Thank you very much. Oh, and Dr. Tedros has something to add.
Yeah, thank you. So with regard to vaccines, you know, when we started the ACT Accelerator, we had 2 objectives. The first one is accelerating or speeding up development of products. And the second objective, fair distribution. So based on that, we have been working, and now there are 3 critical elements for the success of the ACTA. 1, finance, and I think we have said it many times. We need $4.5 billion immediately. And second, it's political commitment. Probably you have followed the G20 summit and the UN General Assembly. Many countries are committing to use vaccines for COVID as global public good, meaning to share it fairly. So the political commitment is important. We have it now, of course, a pledge, but that has to be translated into action because we're going to have the vaccines now. So the political commitment will be real when we see it in action. So that's the second. Third, we have to prepare countries for vaccination, and strengthening the infrastructure will be important. As one of the journalists asked, you know, some of the vaccines need minus 70 degrees centigrade refrigeration. So we may have those vaccines, we may have other vaccines that could be refrigerated between 2 to 8 degrees. but we have to prepare the system for any eventualities or the infrastructure of countries. And that's why we have co-signed a letter with the World Bank, UNICEF, Global Fund, to our country offices to prepare and support countries for vaccination. So these are the critical issues: finance, political commitment that can be translated into action, and preparing the infrastructure. And this will result into sharing. Sharing of the vaccines fairly means faster recovery for the world. And this is in the interest of each and every country. It's only together that we can recover faster. It's through sharing that we can recover faster. And it's only through sharing that we can take care of lives and livelihoods. Thank you.
Just add one thing, because I think something, Dr. Tedros, I think we should say, because in my experience in emergency response and in other infectious diseases, in situations like this, we tend to be unfair first, inequitous, and then eventually the glaring gap is so big, and with activists from community level and others, the world has to turn around and find a way to be fair. In my experience, my professional experience, this is the first time that fairness and equity were built into this project from day one. And that was under the leadership of Dr. Tedros and other leaders who came together and implemented by people like Dr. Mariangela and others, and a wonderful team. But that would not have happened unless someone had stood and said, no, this will be done, but it will be done with fairness and equity as its central tenet. And in my view, that has then created and driven one of the most effective public-private partnerships in the history of science when you think about where we were 10 months ago. And we're not there yet. As Sumia says, we're on the mountain. You said that we're at the base camp. We have to climb the mountain. But the very fact that we have the opportunity to climb that mountain and bring everyone with us is incredible. And we thank you for your leadership, Dr. Tedros, and for the way in which you've reached out to partners all over the world to deliver this. In addition, as someone who works on humanitarian response, this is definitely the first time, in addition to that fair distribution, that there is a specific allocation of 5% for the humanitarian situations in which we may not be able to access people through normal programs. That has never happened before, because it is the refugees and the displaced of the world who are the most forgotten. And it is just wonderful for me, as someone who works in the humanitarian space, and we thank you on behalf of all of those people we serve, for that being at the forefront of the decision-making in this regard. So thank you, Dr. Tedros, for your leadership.
Thank you. And on that note, this is the moment to close the press conference. I think a very, very important point has been made here. I would like to thank everybody. Those who did not get questions, please contact us via media inquiries, and we will, of course, post all the audio file, the transcript, and everything else on the web as soon as possible. I'll now just hand back to Dr. Tedros to say goodbye.
Yeah, thank you. Thank you, Margaret. In my statement earlier, I said COVID-19 is an even pandemic, and 70% of cases and deaths are in just 4 countries. But I would like to correct this. And I would like to thank Kai for keeping us on our toes. And what I should have said is that almost half of all cases and deaths are in just 4 countries, and almost 70% of cases and deaths are in top 10 countries. So apologies for the error. I'm really sorry, and any confusion we caused. But thank you, Kai, for keeping us on our toes. Thank you. And I would like to also thank all our colleagues here, starting from our interpreters, and also to the media who have joined today. Thank you so much, and see you in our upcoming presser. Thank you.